My name's Dr. Gurjinder Singh Sandhu. I'm a consultant in infectious diseases and acute medicine at Ealing Hospital, Uxbridge Road.
And you should have open in front of you your submission. Can you confirm, please, that it's true to the best of your knowledge and understanding, and that you wish to stand as your evidence to the Commission?
Yes, I confirm that.
Now, I want to ask you first of all about the statement that you make that the SAHF reforms are economically driven. Can you say in a nutshell why this is your view, please?
Well, on one of the pages, I've produced a graph, actually. I took the Shaping a Healthier Future graph and I superimposed it onto levels of deprivation. It's page 768. And I put a star over an emergency department if it would close, and levels of deprivation appears as hotspots. And the emergency departments in Southall, Harlesden and Acton are set to close, whilst emergency departments in Chelsea, Paddington and Harrow are set to stay open. As Faria had also sort of said earlier on, Dr. Khan, there is evidence from the US that emergency departments were closed primarily in Medicaid areas, black minority ethnic areas, and areas where you needed a safety net for poor patients. And all of these changes seem to be occurring after the 2008 financial crisis, where top-down reconfigurations in health have been far greater than anything I've experienced in my career. So it is economically driven.
And can you help us with whether or not other consultants at your hospital and perhaps beyond share those views or differ from those views?
All of the consultants from the Medical Staffing Committee wrote a letter to Jeremy Hunt at the time of the independent reconfiguration panel. It was a universal opinion amongst the paediatricians, obstetricians, radiologists, consultant surgeons, consultant physicians that these changes were not good for our population. Yet, as Colin has inferred, our medical director still managed to sign one of those letters, which totally betrayed our viewpoint.
Pause there a moment. Can you confirm, first of all, that the letter you're referring to is the letter dated February 2013?
Yes, it is.
And can you confirm whether or not, to the best of your knowledge, the consultant body at Ealing continues to hold the views expressed in that letter, or whether that has changed?
The consultant body at Ealing continues to hold this viewpoint, and I could quite easily do what Shaping a Healthier Future does and get them to sign another letter to say they share this viewpoint.
Now, you've just mentioned the letter relied upon by the Secretary of State, signed by the Medical Director of Ealing. Can you tell the Commission a little bit more about how that came about and how it came to be signed, please?
Well, I think Colin's already sort of mentioned this a bit as well. We were feeling momentum building up as the independent reconfiguration panel was getting there. You've obviously heard a lot from residents of Ealing, Ealing Council, Ealing consultants. We had a big rally where the elderly, the disabled walked all the way from Southall Broadway down to Ealing Common. You know, that was a long distance for them to walk, and the momentum was there that there was outrage against these changes. And what I heard is, and I've read in subsequent articles in the news, that the Prime Minister and the Secretary of State were anxious about these changes, and Shaping a Healthier Future ran around, got the same letter for the Ealing CCGs and got people to sign it, and the same letter for the medical directors and got them to sign it, and suddenly came out with this statement: this is clinically led and clinically supported.
Why is it that you say that those medical directors signed it if it wasn't something perhaps that they subscribed to, or was it?
Because we then called our medical director up to the Medical Staffing Committee and said, why did you sign a letter which totally contradicts everything we stand for in this committee, in this hospital, with our community, with our local GPs? And he said he didn't read the content of the letter he signed.
Are you able to help in terms of any of the other medical directors, or is that the extent of the knowledge you have?
I think we were only able to push our own as to why he betrayed us.
Now, in terms of the reconfiguration of emergency services, can I ask you what it is that you understand by an urgent care centre, and what you understand the proposed urgent care centre at Ealing will actually do?
An urgent care centre will not see patients brought in by ambulances. An urgent care centre will not have an chest pain unit associated with it, a coronary care unit associated with it. It will not have the backup of consultants in orthopaedics, consultant physicians, consultant surgeons, consultant paediatricians. It will be run by GPs. An urgent care centre, we did actually, right at the beginning of this process, see a list of exclusion criteria for Care UK urgent care centres, and it seemed like you really could just come to an urgent care centre if you'd sprained a muscle. And even then, you couldn't be in too much pain because you couldn't really handle too much in the way of painkillers that an urgent care centre could give out.
What happens to cases that an urgent care centre can't deal with, please?
Currently, with a co-located accident and emergency department, the urgent care centre is able to refer those patients onto the accident and emergency department, and the specialists within the hospital can see that patient and admit that patient. In the future, where you've got urgent care centres which are standalone without emergency departments, then it's my understanding that that patient will have to make their own way to an appropriate facility that can manage them.
Have you been given any information, or do you have any knowledge of what if any transport can be provided or will be provided in those circumstances?
I have no knowledge of that.
Are you aware of whether or not ambulances will be called to UCCs to transfer patients or not?
I'm not aware that they will. I mean, the idea is that you would make your own way to an urgent care centre, and presumably you would make your own way from there if it's not the right place.
Now, thinking about the closures which have already happened in Hammersmith and Central Middlesex, do you have any comment on the impact, if any, that those closures have had? So particularly on Ealing, the hospital that you're at.
There is a human face to Collins graphs. You see Collins graphs where everything's hovering around 90% and then plummets down to the 50s. Now, when you work as an acute medical physician, you can walk into an emergency department and see every resuscitation bay being fully used. The paediatrician's in one corner over winter dealing with viral pneumonitis. You're dealing with septic patients. You then identify as a consultant a patient who needs ITU. You run up to ITU. You're thankful you see the matron there and say, "Matron, I need an ITU bed." She says, "Well, step this way, let me show you the recovery theatre spaces," and every single space is being used for ventilating patients. So you're running intensive care units at over 100% occupancy. You then start phoning the other intensive care units around the area, Hillingdon, Northwick Park, West Middlesex, and none of them have intensive care unit beds. That's just the acute end of things. Then every assessment bay in majors is full of patients. You may well have the elderly patient who's fallen down and spent most of the night on the floor, is hypothermic, and we possibly haven't got around to getting her something to eat or drink yet, kind of thing, because everyone's so busy in resus dealing with the acute emergencies. So the spill-on effect that we witnessed of in the emergency department was pretty much so a grim and gridlocked scenario.
And what do you say will happen if there are further closures?
Absolutely catastrophic. It will have a huge impact on the morbidity and mortality of this population. We're talking about people who are waiting longer for the ambulance to arrive, then they're waiting longer in the ambulance to get to their destination, then they're waiting longer for the ambulance to offload them, then they're waiting longer in the A&E to be seen. Then there wouldn't possibly be the appropriate intensive care unit bed for them at that location. If you look at something like sepsis, or you look at something like renal failure, or you look at the unconscious patient or respiratory distress, all of that amounts to minutes, hours, which would be life-saving, where cells are dying, kidney cells are dying, patients are dying.
Now, you talk about black breaches for ambulance wait. I think you've touched on it, but could you just explain to the Commission, please, exactly what they are and what it is that the graphs and the figures that you've included actually mean?
I mean, before I do that, I did hear some comments earlier on about how many ambulances actually come to Ealing Hospital, and that wasn't true. And I've emailed Peter the exact ambulance statistics for how many come through to Ealing Hospital. A black breach is where an ambulance is taking more than 1 hour to offload a patient so that they can actually be seen by the accident and emergency staff. If we look at the graph, black breaches last year, we had possibly 142 in Northwick Park, about 32 in Ealing. This year there's been 633 black breaches in Northwick Park. And that's not complete data, because the complete data will be gathered by April. So that's 633 patients waiting more than an hour to be offloaded from the ambulance. All hospitals in North West London saw a rise in black breaches after the closure of these emergency departments.
And is that something that you know, do you know that to be something that's continuing, or has it changed in any way?
I think it's got a little bit better as a lot of the sort of so-called winter crisis problems had started to get better. But I do have photos on my mobile phone which I take as I go home where there are 9 ambulances lined up outside Ealing Hospital Accident and Emergency Department.
And is that something very recent?
Yeah, I can send that photo from about 2 weeks ago. I can send it over to Peter.
And what do you say the impact will be if that doesn't improve?
To be honest, I mean, if I'm just to put into context a visual story, a man who's got cancer has chemotherapy at home, and the district nurse would come round and take the chemotherapy off. But when she arrived, she noticed the man wasn't very well and felt he needed to come into the hospital. The family inquired, and he was actually unconscious and he was on the verge of fitting, and the family sort of phoned the ambulances 111 and eventually realised it was going to be better to bring him in themselves. So you've actually got a son carrying his 80-year-old cancer father into an emergency department because it's easier than waiting for an ambulance. You know, that image is developing world.
And is that an isolated incident or something that you have more knowledge of?
That's an isolated incident. I can only talk about the on-calls that I've done. But the stories that people will tell me about waiting for ambulances or waiting to get to emergency departments are already horrific. You start removing further emergency departments from this infrastructure, it will just get worse.
Now, just thinking a bit about the out-of-hospital services, can you help with your understanding of the quality and availability of those services now?
I do not categorically believe that any out-of-hospital services that I've seen people write about are going to stop acute hospital admissions. We've heard about musculoskeletal services. Well, that's not going to stop a granny slipping on the ice and breaking her hip and needing an operation. We've heard about diabetes networks. Well, that's not going to stop a teenager coming in with diabetic ketoacidosis, or people coming in with comas, or diabetic patients coming in with renal failure needing dialysis, or diabetic patients coming in with ischemic legs needing surgery for them. We've heard about dermatology out of hospital services. Well, my understanding is that's a photograph that a dermatologist might look at on Skype or something, but that's not acute emergency care, it's outpatient care. You're not going to prevent acute hospital admissions with these kind of out-of-hospital services. You then talk about intermediate care services, whereby you've got people to help the elderly get back into their homes. What Shaping a Healthier Future wanted was a system which was admission avoidance, but actually what clinicians want is supported discharge. We acknowledge that when an elderly person comes in and they're confused, or they have a urinary tract infection, they may actually be quite aggressive towards their spouse. We can't just say, we're going to send you home with some antibiotics and there'll be a physiotherapist that will make sure you can get to the bathroom. You actually need to admit that patient, make an assessment of what's going on. Making assessments of elderly patients as an acute physician is not an easy task. You shouldn't be doing it in the emergency department and sending someone home quickly. You need to actually have time to see, is this early dementia? Is this delirium? Does the patient need a scan? What's going on? We're living in a world with resistant bacteria, resistant organisms. You know, we heard Faria say, 1 tablet, off you go home. Well, we don't work like that anymore because amoxicillin doesn't work anymore. And to be honest, you may well need to be in hospital for a week with intravenous meropenem. You know, the bugs have changed the goalpost as an infectious diseases doctor, I would say.
Particularly thinking about your elderly patient group in that case, where does the input from social services fit in? I wonder if you could encapsulate that normally, perhaps.
It's just frightening. I'm sorry, it really is just frightening, the lack of social care for people in the community. I work with 50% less social workers than when I started as a consultant at Ealing Hospital. I feel that we are battling with social services, because we heard earlier on from Julian Bell and the council about cuts to social care. Now sometimes it will be very, very clear that someone needs to go to a residential home or go to a nursing home. You know, if Grandad keeps putting the electric kettle on the gas hob, then that family can't wait for the big kaboom before they all come in. And when we've identified that we need more care space for this person, it almost feels like social services have got a remit from higher above. Don't send them to a residential home, it's going to cost too much, you've got to get them home, you've got to get them back out, whatever it takes, get them back out. Well, I'm sorry, but the doctors, the nurses, the occupational therapists, the physiotherapists are not going to do that. They're going to keep that patient in hospital until we know it's safe for them to go somewhere in the community that's safe. And then you've got this situation which is called bed blocking, which we don't like the term, but it does have the equal impact on the emergency care crisis.
So to fulfil the objectives that Shaping a Healthier Future has of having an infrastructure in community and primary care that allows a reduction in the bed blocking, if you like, allows those things to flow through the system, what's needed?
Well, then you actually look at a much greater societal issue. The first thing that's needed is that you put the patient at the centre of what you're doing and not the buck at the centre of what you're doing, which was what appears to be happening. You are talking about an ageing population, which every document starts with, but you almost feel that people want the second line to be, well, hurry up and die then. Because in reality, we need to invest more for our elderly. They were here at the birth of this NHS, and they are here at a time when we're dismantling it and they need it the most. We would have to accept, with rising rates of dementia, that we probably do need more in the way of nursing homes and residential homes for people to actually be safely discharged to, but that investment is never coming.
Would you like to wait there, please? There may be some questions from the Commissioners.
Recognising acutely that I think I fall into that category. I just want to see, given your experience, what category of investment is required here, do you think? I mean, what kind of figures are we talking about? And what kind of person power is going to be required?
I mean, I'm not a politician, I'm not an economist, I'm a doctor. And what I would say is that you would really need quite significant levels of investment in community. And even then, I don't believe you can take away acute hospital beds, because you can take an influenza outbreak like the one that we had in 2009, 2010 with pandemic flu, which just crippled our population and filled our intensive care unit beds. We need an acute buffer in the community, in the hospitals, and we need safety nets in the community. So although it sounds like, you know, the doctor that says you need to fund everything more, that is actually the national debate we need to have. Do we need to just shove up the taxes and actually really invest more in social care and healthcare? And I believe that is probably what we do need to do.
Right, thank you.
Yes, you said to the People's Inquiry recently that if you're going to run as if the community is a virtual ward, it needs to be staffed as a virtual ward. And you were talking quite positively about how you'd like to be able to discharge patients with support back home. So, I mean, I'd like you to just expand a little bit more on that. What type of teams do you think would be needed in the community to make this a real possibility?
Okay, well, let's say, what do you have on a real ward? Well, you'd have a ward where you've got a nursing to patient ratio of, say, 6:1. You've then got a junior doctor that is able to be called by a bleep 24/7 to come in and deal with the issues, and then you've got a senior doctor that's on call whether they're on site or at home. So are you going to invest in the community to that degree? Well, district nurses and their workload is huge. The time they get to spend with patients is minimal. GPs are not on call 24/7 to be able to come out and deal with the acute issues. I help run a home IV antibiotic service, and we always say we need a backup plan. So we can have that patient out in the community on the virtual ward under my care getting IV meropenem or whatever it is, but if their line becomes dusky or if they start having shivers, then they need to come back to the emergency department and be readmitted into hospital. So you need to staff the virtual ward in exactly the same ways or with the same principles in mind, the same safety principles in mind that you staff hospitals. And sorry, this is just one sort of tangent. I don't know if I can make this point, just on safety again. As a junior doctor going through my training, risk management was a concept that was drummed into me. And post-Francis report, the duty of candour and transparency is something that is very, very clear to me. When you see graphs where emergency care plummets off the scales kind of thing, and then you have the CCGs and Shaping a Healthier Future submitting to your commission 4 lines of what they feel has happened post-closure of Hammersmith and Central Middlesex Hospital, then you do not have clinicians who are practicing risk management. You do not have people who have stopped and paused and asked themselves, what have been the consequences of our actions? Are we going to be transparent with the population and say, these have been the consequences of our actions? Are we going to categorise those risks, and are we going to stop closures any further until we know exactly how we can do so safely? That's not happening.
Thank you. Just one question, but just one comment first. As a young doctor, I found the answer when I used to say, well, he's leaving the gas on, we've got to do something. Was, oh, we'll put in an electric hob. That was their temporary measure, God bless them.
That was the temporary measure. It still is, to be honest.
Still is, the electric hob thing. You know.
Yeah.
Just more seriously, I understand that perhaps at Charing Cross, perhaps at Ealing, there will be this thing we haven't got a grasp of yet called a local hospital. I haven't yet been able to pin down in my mind what that means. It's certainly suggested that the word hospital is being used to allay the public's fears. But what may be, at its best for these local hospitals, there may be, for example, it was suggested to me by a specialist that, oh, well, it might be something very good. There could be 30, 40, 50 beds remaining, which will be used to tide over the elderly, for the elderly admissions during acute problems. And at first sight, I thought, oh, good, that'll make it easy to get them in. And then I thought, that's a 2-tier system. For example, I have a relative who had now passed away, but had a heart valve replaced to get a better quality of life. I've attended a lecture some years ago at which it was suggested that you would replace a heart valve in somebody who's terminal in a 6-month prognosis or with a cancer to have a better quality of life. In other words, you are now treating a patient or a person who would never be treated, who will need, very briefly, intensive care facilities. So it seems to me that if you're going to have these beds reserved for the elderly with their acute pneumonias that only need 2 or 3 days we can get them out, what happens if their pneumonia goes off? There's no intensive care unit to admit them to. Does that mean you're not going to admit them to intensive care unit? Or are you going to be able to transfer them? Now, I'm trying to lead you, but do you have any thoughts about that?
I have absolutely the same viewpoint, and I would use the word discriminatory. I believe that at the moment, if an elderly patient comes in, they will have access to a diabetes physician, they will have access to a cardiologist, they will have access to an intensive care unit, they will have access to a full rehabilitation team through a major hospital where all specialties are present. Quite often the elderly are coming in with polypharmacy. They're on huge numbers of tablets, and we can come along and we can work collectively and we can rationalise it. You then turn that into a local hospital where they don't have access to all of those clinicians, but basically the young people have access to all of those clinicians, and you have discriminated against them. We had step-down beds or community rehab beds over the winter crisis where we could admit someone into one of these beds. And you may well get there, but 3 days down the line they deteriorated and they were readmitted back into the acute hospital. And luckily the acute hospital was still there for them to be readmitted into. But when that acute hospital isn't there, then I do fear that the elderly will be discriminated against and put into smaller hospitals where they don't have access to everything they're entitled to. And the other thing that then happens, I think, which is a bit frightening to be honest, but is happening in the medical profession, is the do not attempt resuscitation orders, which you've then got people making decisions, I believe, on the basis of resources available to the country and its health, that this life is worth saving and that one isn't.
Thank you.
Just to follow that through a little bit, are you saying that, because of course one of the big areas that's disappeared in the NHS since 1993, I think, is the geriatric beds, the specialist and geriatricians are generally actually very hard to find now across the NHS. Are you saying what we're getting is like an equivalent of that emerging if these small hospitals are built, only taking basically elderly patients under those conditions? You're getting a geriatric bed but without geriatricians and without the actual resources to treat them properly.
We have fantastic geriatricians, but geriatricians work with the rest of us as consultant physician colleagues. They work with cardiologists, endocrinologists, infectious diseases doctors. I don't want my geriatricians working in a separate hospital to me. As an infectious diseases doctor, I am now seeing an ageing HIV population and I want a geriatrician that I can refer my HIV dementia patient to. We need to not fragment people on the basis of what economically works for us as a healthcare system and actually still keep things in one place. Another example, I mean, centralization we've talked a lot about, but when my elderly man who has renal failure and his hip dislocates and he's got a weak heart that the Brompton says he needs an angio for before he can have his hip done, trying to find one hospital in northwest London that could do all three of those was difficult, because Hammersmith could deal with renal and cardiology but didn't have orthopaedics to deal with the hip. St Mary's could deal with the trauma and the hip but couldn't deal with the cardiology and the renal. We actually ended up admitting him onto our own ITU, dealing with the renal, getting our cardiologist to deal with the cardiology, and then popping his hip. You know, they're telling us we have to send people to these central hospitals, but the central hospitals haven't got everything under one roof. You have this farcical situation where you had gynae oncology at one point. I don't know what the system's like now, but gynae oncology at one point was at Charing Cross Hospital, whilst gynecology was at Queen Charlotte's. It just doesn't make sense. They're talking about a maxim of centralisation when it doesn't even exist at the moment.
Thank you very much, very clear.